When we talk about immune-mediated disorders, these are disorders caused by dysfunction of the immune system. The immune system works well when it can recognize non-self entities when they invade the body. In immune-mediated disorders, the body in some ways fails to make the distinction and in turn may attack the self, the body's own tissues. The mucosal orders we will cover are recurrent aphthous ulcers, major and minor, lichen planus, lichenoid reaction, and mucous membrane pemphigoid. Recurrent aphthous ulcers, the minor form, we believe there are immune defects that are present with the patient. They present as very small vesicular lesions. The causes can be allergy, hormonal, infections, nutritional deficiencies, and probably most commonly stress. So there are two forms, the minor and the major. These are also known as canker sores. Recurrent aphthous ulcers, the major form, presents as larger bullous-type lesions with a longer duration, upwards to 3 to 4 weeks. Lichen planus is a T-cell related immune defect. There are several types. The reticular, which the distinctive lesion is Wickham striae, atrophic, and erosive. The reticular form is distinctive due to the pattern it presents. In the main, lichen planus is asymptomatic or only mildly symptomatic. The erosive form is the most symptomatic. It is also considered to be potentially malignant and should be watched with subsequent exams. Lichenoid reactions are similar in appearance to lichen planus. Upon questioning the patient, a history of exposure to some irritant, cinnamon in particular, is usually discovered. I need to stress that amalgam allergies are exceedingly rare and should not be the go-to diagnosis for lichenoid reactions. Once the source is resolved, the source is determined, the removal of the source will usually resolve the lesion. Mucous membrane pemphigoid is a distinctive oral and ocular, has distinctive and oral ocular lesions. It occurs because of a split between the epithelial and connective tissue layers. It's considered a type 2 hypersensitivity reaction. What makes mucous membrane pemphigoid distinctive is there's something called the Nikolsky sign. The Nikolsky sign is when you take a piece of gauze and rub it across the affected tissue, you will actually get peeling of the epithelial layer. So Nikolsky sign is the separation of the epithelial layer from connective tissue when disturbed. Any mucous membrane can be affected, and since the eye is also a mucous membrane, that's why the eye sometimes is involved. Mucous membrane pemphigoid is usually self-limiting and may be treated with steroids or anti-inflammatory medications. The four entities discussed here have oral lesions, but also skin lesions, making them more extensive. We have discussed lupus erythematosus and Sjogren's at length, so we will touch on them very briefly. Pemphigus vulgaris is a serious systemic disorder. Fortunately, treatment with anti-inflammatory steroids has cut the risk of mortality with pemphigus vulgaris. So in pemphigus, there's this life-threatening, widespread blistering of the skin. Okay. The oral lesions usually appear first, and then the skin lesions later. Erythema multiforme has triggers that set off the immune system. Usually it is some kind of bacterial or viral infection, or drugs can also do that. drugs that the patient is taking. Erythema multiforme can also be idiopathic, where there is no cause that can be discerned. Stevens-Johnson syndrome is a form of erythema multiforme that has lesions on the skin, the eyes, the oral cavity, and genital lesions. We've talked about lupus erythematosus and DH366. The sign to look for is the butterfly rash, which is very distinctive as it appears on the cheeks and the face of the person with lupus. We've talked also about Sjogren's. This gives you the overall kind of effect that Sjogren's has, but we've just talked about this in the last series of lessons, and so this is just kind of a review of what the possible oral symptoms might be. Probably the most common immune disorder is contact allergies and angioedema. Contact dermatitis occurs when there is a reaction on direct exposure to an allergen. So the causes are many. It could be foods, metals, nickel in earrings for those of us who wear earrings. Some people cannot wear inexpensive type pierced earrings or earrings simply because of the occurrence of nickel in those earrings. Dental materials are rare, and I need to stress this. We very rarely get contact dermatitis from a dental material. Oral hygiene products, toothpaste, mouthwash, and indeed cosmetics for women, lipsticks, lip gloss, things of that nature. Latex is the one. This is why we no longer use latex gloves, even though they are very nice gloves, because of the fact that latex creates a very, very intense contact dermatitis. There's a need to determine the source of an allergy. In other words, need to know what the patient or what you, if you have a contact allergy, what you came into contact with. And then the best thing is to avoid that source. Just don't use that product or come in contact with that particular allergen again. Angioedema is an allergic reaction. While it looks very bad, as you can see by the illustration on the right, it is self-limiting. If it is severe, then there can be treatment for it. Our biggest problem with angioedema is usually local anesthetics. The patient will be fine the day they leave the clinic, but they will call you in the morning and they will say, my lip is swollen and how come? And usually we try to rule out hopefully the patient hasn't bitten their lip and caused their lip to swell. But if it is indeed angioedema, then we need to know. As I said, it's self-limiting. Usually we will prescribe something like Benadryl to bring down the swelling and inflammation. This concludes the lesson on immune-mediated disorders. Again, if you have any questions, comments, or any issues, don't hesitate to contact me.